Hi everyone, welcome to this talk on ultrasound of the optic nerve. I'd like to thank the organisers for inviting me. It's a real privilege to be able to share this with you from the other side of the world. My name is Dr. Ashley Miller and I'm a consultant in intensive care medicine in the United Kingdom, where I'm co-chair of the ultrasound committee of the Intensive Care Society. Ultrasound of the optic nerve has been generating a lot of interest in recent years. Ultrasound gives us a window into the brain, whether it be transcranial Doppler or optic nerve assessment. The idea of having a non-invasive imaging tool you can use at the bedside to help decide if someone has raised intracranial pressure is very attractive. Now, I'm not going to talk about any studies or evidence because you can go and read that stuff yourselves and it will be pretty boring. I am, though, going to go through some pearls and pitfalls of the technique because it's often done wrong. Let's start with the anatomy of the eye. Now, the idea with ultrasound is that we can see the optic nerve as it exits the back of the globe. The sheath around the nerve is an extension of the dura, and a few millimetres behind the globe, the nerve has room to expand if intracranial pressure is high. Papilledema is also a feature of raised intracranial pressure. This can be seen with ultrasound as elevation of the optic disc by more than 5 millimetres into the globe. However, it's an insensitive sign, can take time to develop, and so is of limited use. Because of this, ultrasound for raised ICP mostly focuses on optic nerve sheath diameter. And this is the kind of image we see on ultrasound. We can see the slight bulge of the optic disc, the hypoechoic nerve, and the hyperechoic sheath on either side of the nerve. However, we can also get pictures like this. Here I've moved the probe to a slightly different angle, showing a black tube-like structure behind the eye, which gets wider as it goes deeper. This isn't the optic nerve. It is in fact artifactual echo dropout. A shadow, in other words. We can also get pictures like this, where the echogenicity of the nerve and sheath appear to have reversed. This is another example of us looking at something other than the actual nerve or sheath. So if you look on Google, YouTube and Twitter, and even in some published studies, you'll see examples of these kind of images with incorrect labelling and incorrect measurement of the optic nerve sheath. So to get this right, let's go back to our anatomy. Here's our eye again. Firstly, the optic nerve passes through a collagen mesh-like structure at the back of the eye called the lamina cribrosa. The complex here of nerve, sheath and this mesh can very easily create artifacts on ultrasound. So how much of what we see is the nerve and its sheath and how much is artifact is not always clear. Secondly, the optic nerves are also not straight structures. Not only do they travel medially, but they can curve in any axis. And this MRI picture allows us to appreciate these curves in just one axis. This clip demonstrates how much the optic nerve can seem to curve from where it exits the globe and how this changes depending on the angle of inclination. Here I'm starting in a lateral position with the probe angled medially before gradually tilting my probe to a central and then medial position. Notice also that we can see a slight bulge from the optic disc, which I've tried to keep in view whilst moving the probe. So this makes sense. This clip shows you how I'm moving the probe to get these images. I'm tilting from a lateral to medial position and then back again. If we add coloured Doppler to the scan, so we can see the blood flow in the central retinal artery and vein, this helps us see the nerve changing position even more clearly. And this confirms that we are looking at the optic nerve. We can see again how the course of the nerve appears to completely change depending on the angle we are looking at it. Here it starts by travelling to the left of the image, moves centrally, and then travels off to the right as I change the angle of inclination. Now here I've made an effort to centre this image perfectly. We can see the slight bulge of the optic disc, the hypoechoic nerve and its hyperechoic sheath running down in a straight line, and the retinal vessels running straight down the middle of the nerve, at least for around 5 millimeters. Now I'm confident here that because of the vessels, I'm actually seeing the first 5 millimeters of the nerve. Deeper than that, I can't be sure about what I'm looking at. Now we are sure what we're looking at, we can do some measurements. The diameter is measured perpendicularly to the nerve 3 millimeters behind the globe. I've measured outer edge to outer edge of the hyperechoic sheath, not the black shadows to either side of this. We can see the measurement here, which is my eye by the way, is 0.48 centimeters, which is almost exactly the mean measurement found in studies measuring optic nerve sheaths with MRI. I've also measured the optic nerve diameter without the sheath, so inner edge to inner edge, which here is 0.33 centimeters. This again correlates well with published MRI measurements. And just for reference, so you know it's not only my eye that looks like this, here is an image of my wife's eye, where I've got an almost identical image with the nerve centered in the picture. Again, please don't get confused between the hyperechoic nerve sheath and the shadows on either side of it. I want to show you now what it looks like when we measure the nerve from a slightly off-center angle. Here I'm directing my probe laterally to medially. We can see the nerve and the direction it's running in. Its sheath does not appear to be visible. The Doppler confirms it's the nerve, and the measurement is almost identical to the one we got from a central position. Please carefully observe the artifactual shadow running straight down from the lamina cribrosa, which must not be confused with the nerve. Including this in any measurement would be a big mistake. Here I've moved the probe to look from a medial angle. Again, we can clearly see the nerve running in the other direction this time, and again the measurement is virtually identical. As before, we cannot see the sheath clearly, but we can observe artifactual shadow. Now this is what happens if I don't distinguish the nerve from artifact and measure the artifact instead. Here I've got a measurement of 0.58 centimeters, making it look like I may have raised intracranial pressure. Whereas if I measure what is actually the nerve, perpendicularly to the blood flow, the measurement is 0.31. So, there are a few really important take-home messages. Firstly, we need to make sure we know what we are looking at and how to optimize our pictures. So center the nerve in your image so it's running straight down from the back of the eye. Next, you need to identify the bulge of the optic disc. You need to use colored Doppler to make sure it's the nerve you are seeing rather than artifact, and that it's running in a straight line. The nerve is the hypoechoic area that the vessels are running through. And the sheath is the hyperechoic areas on either side of the nerve. And don't make the mistake of thinking any shadow on either side of the nerve is part of the sheath, or you'll come out with a falsely enlarged measurement. We also need to critically evaluate existing studies on measuring the optic nerve with ultrasound. Some of these have incorrectly measured artifacts rather than the actual nerve or sheath. And this may account for discrepancies between studies when comparing the size of the nerve with intracranial pressure. It's worth noting that if the nerve is swollen, the artifact may well increase in size too, and so studies measuring it incorrectly could still have results that have some correlation with intracranial pressure. It's really important that future studies are rigorously standardized if people are going to have faith in this technique. And standardization means making sure we obtain the images in the right way and understand what we are looking at. And that's by doing all the things I've already talked about. Now, it may turn out to be that the greatest accuracy is achieved by measuring the nerve from a lateral position, which allows greater edge definition due to the problems with axial resolution with ultrasound. I haven't found it as easy to see the nerve sheath this way, but if it inspires you to do a study on it, please go for it. And finally, a couple of important safety tips before I go. Please note I've used the ophthalmic setting on this GE Venue machine, and this ensures a low thermal and mechanical index which will not cause damage to the eye. And finally, keep scanning time to a minimum. Thank you very much for listening.